Hello, I am Dr. Gus Livaditis, a prosthodontist practicing in Baltimore, Maryland. My goal for this presentation is to inform dentists of a new explanation for the occurrence of deep bites with or without anterior wear, an acquired condition in adults. Before I begin, take a moment to review appropriate disclaiming information. Over the past years, I questioned a couple of prevailing concepts, and in this past decade, I began investigating through existing literature and clinical observations the cause of anterior wear and deep bites while the posterior occlusion appeared intact. The investigation over the past 7 or 8 years was not a clinical or research type of study, but rather a follow the clues or follow the evidence process. This led to revealing an unrecognized diagnosis and etiology. Hence, patient-induced posterior dental intrusion will be shown to explain anterior wear and/or deep bite and will position posterior dental intrusion with 5 other forms of collapsed bite: loss of posterior occlusion due to missing or non-occluding posterior teeth, tooth substance loss with reduced OVD including 3 forms: attrition, abrasion, or erosion, and posterior bite collapse according to Amsterdam, the most challenging dentitions for restoration. PDI is described as an adult acquired dental condition. It's not congenital or growth and development. This presentation utilizes fully dentate patients to review the diagnosis of PDI, even though PDI may have occurred prior to the loss of substantial teeth. With missing teeth, the evidence, the essential clinical features, may have been obscured. For similar reasons, dentitions with implants and with numerous crowns are excluded. Implants would not allow intrusion, although the opposing natural teeth may intrude. And crowns conceal anatomic references which interfere with the evaluation of significant clinical features. The diagnosis of PDI is presented at the beginning of this presentation, and each diagnostic feature will be described to support the diagnosis and etiology while challenging some current concepts. The diagnosis consists of 6 essential clinical features and 3 non-essential but supportive features. If one or more essential features are confirmed absent, an alternative diagnosis should be considered. But that is absent, not a failure to observe or detect. Supportive features may further confirm the diagnosis of PDI, but are not required to establish the diagnosis. Once familiar with the entity of PDI, any one of the features, essential or supportive, may encourage further examination for PDI. The features most likely to prompt further investigation include deep bite or anterior wear. Let us review the essential features. Posterior dental intrusion is a clinical feature, but it also serves as a name for the clinical condition, more appropriately referred to as patient-induced posterior dental intrusion. The term patient-induced is what established there to be a condition that has not been acknowledged to occur, and the reason it was selected as the name. Certainly, other forms of intrusion, including intrusion of posterior teeth, are familiar. Posterior dental intrusion is a clinical feature in itself. It may be the cause of one or more clinical features, but it is not the cause of the PDI condition. It is an end result of the PDI condition. Posterior dental intrusion as a feature will be reviewed later in the presentation. These 2 features are linked and should be discussed together. Deep bite and anterior wear may occur alone or together. If all posterior teeth in one or both arches are worn, eroded, intruded, or even missing, a decrease in vertical dimension may occur. And that reduction in OVD readily explains deep bite or anterior wear. If PDI is considered to occur, proportional posterior wear cannot occur Otherwise, one of the other types of collapsed bites should be considered. The term proportional takes into consideration the rotation of the mandible around the intercondylar hinge axis. A 3 mm opening or closure at the incisors is often considered to be 1 mm at the second molar, or a 3-to-1 ratio. While the figures 3-to-1 may be contested, the term proportional is appropriate. Orthodontic literature typically avoids this issue by referring to changes in vertical dimension as degrees of rotation of the mandible. If loss of vertical dimension is confirmed, anterior teeth may respond with increased overlap, anterior wear, mandibular crowding, or maxillary splaying with or without mobility, or a combination of the above except for the maxillary splaying, which does not occur with PDI. With anterior wear and when the posterior dentition appears intact, a common response includes the anterior teeth have erupted to compensate for the wear. The concept of compensatory eruption in situations when the anterior teeth are worn and continue in occlusion is challenged in this presentation. On this patient, this presenter proposes that posterior intrusion has occurred and the response of the anterior teeth is anterior wear. Note the CEJ level of the mandibular anterior teeth is higher than the posterior teeth. This forces a choice: eruption of the mandibular anterior teeth or intrusion of the posterior teeth. When the anterior teeth are considered as compensatory eruption and the posterior dentition appears intact, the vertical dimension is generally presumed unchanged. This presumed unchanged concept of OVD is reported widely in both lectures and publications without substantiation. This presentation will identify criteria that will support intrusion of posterior teeth with signs that the vertical dimension has changed or has been reduced. This is a patient with an obvious deep bite beside the excessive length of the maxillary central incisors. No significant or proportional wear of the posterior teeth is observed. Excessive eruption of the mandibular teeth may be considered, but would not or cannot be considered compensatory. Or instead, the mandibular posterior teeth may have been considered to intrude. Either option would explain the discrepancy in the occlusal plane and distorted level of the CEJs or Wheeler's cervical plane. Further discussion will provide evidence to support which has occurred. Let us continue, but before describing intrusive passive eruption, which is a form of altered passive eruption, some terminology should be clarified. The term passive eruption causes some confusion. The periodontal literature describes passive eruption as the migration of the gingiva along the crown of the tooth to the cervical zone or within 2 mm of the CEJ. It does not refer to movement of the tooth or recession of the gingiva. However, orthodontists use the term to refer to normal eruption of teeth, while the term active eruption refers to driven eruption as an orthodontic movement of teeth. While prosthodontists may use the term to refer to continuing eruption or even compensatory eruption. In any discussion, the term should be clarified up front for a productive exchange of concepts. In this presentation, passive eruption refers to the cervical migration of the gingiva, or the periodontal description. Altered passive eruption is the failure of the gingiva to migrate to the cervical zone. It is a description and not etiology or explanation of cause. It is also referred to as delayed and retarded passive eruption. In this presentation, I refer to all three terms as altered passive eruption, or APE. It is commonly observed in late adolescents and young adults and it is also referred to when describing a gummy smile. The term intrusive passive eruption, or IPE, is introduced by this presenter with specific characteristics and a specific etiology. The etiology is intrusion of teeth when the gingiva follows the teeth, but not completely. Murakami and others, while intruding anterior teeth in monkeys, determined the gingiva followed the intrusion of the teeth, but only 60%. Erkan and others intruded teeth in humans and reported the gingiva following the teeth, but only 79%. Both studies revealed a form of altered passive eruption. The definition of IPE is abnormally occlusal high level of the gingiva due to intrusion of the teeth. If the teeth are orthodontically intruded, IPE can occur at any area in the mouth and any age. In PDI, intrusive passive eruption is observed only on posterior teeth and precisely transitions to normal passive eruption between premolar and canine. And it can be seen at any age. It occurs bilaterally, but not necessarily on the same arch. Observe on these three patients the precise transition from altered passive eruption to normal passive eruption between premolar and canine in mature adults. Premolar anatomy is insignificant. It may occur when first or second premolar is adjacent to the canine. It is bilateral in occurrence, but does not have to be in the same arch, and it's normal and healthy gingiva. The position of the gingiva is not due to inflammation. These features serve for differential diagnosis with other gingival pathologies or conditions. Intrusive passive eruption is the first report of altered passive eruption to be due to PDI. It's a very important supporting feature for PDI. Now, Dr. Morton Amsterdam first described altered active eruption where the alveolar bone was unusually high, preventing the gingiva from migrating to the normal cervical zone. Unfortunately, the report was not an archived journal article. His description of active passive eruption is cited often as a report. It has been suggested by a colleague of Amsterdam that the report may have been a continuing education handout. A detailed description is not available, and it is not possible to link it as support for PDI, but nor to challenge the diagnosis of PDI. I wish I had more information about the observations of altered active eruption by Amsterdam. Now, clenching is a very important clinical feature of PDI, and indeed is considered to be the cause of PDI. Before delving extensively on this feature, it is important that we separate the parafunction of clenching from the general parafunction of bruxism, which includes grinding or gnashing of teeth, and clenching or bracing of teeth. Grinding includes movement of the mandible in a lateral protrusive and protrusive manner under pressure, creating wear facets which are near horizontal with the occlusal plane and forming what some people call mating surfaces with the opposing teeth. Clenching is more of a static application of force on the teeth and may result in near vertical wear of teeth in relation to the occlusal plane. If clenching is proposed to be the cause of PDI, the following aspects of occlusal forces should be reviewed: magnitude of force, direction of force, duration of clenching events, lifetime exposure to clenching forces, and very importantly, anchorage. Reports specific for clenching force magnitude are not available, possibly for reasons to include clenching has been considered part of bruxism and studies are not specific for clenching. Clenching forces may vary from moderate biting force to maximum biting force. The term clenching may refer to the parafunction of clenching or in general to any degree of bite closure. You may ask the patient to bite down or to close or to clench your teeth. Clenching may be used as a general term. Nishigawa reports forces of 22.5 plus or minus 13 kilograms of force during bruxism. Clenching force will shortly be compared to orthodontic force required to intrude tooth segments. Direction of force during clenching is axial and ideal for intrusion. Some tilting of teeth may occur, which also may cause reduction of OVD. Wide occlusal tables and intercuspation of posterior teeth is suitable for intrusion. Anterior teeth respond quite differently to clenching. Again, specific figures for duration of clenching events are not available. Clenching event duration may vary widely between individuals. Duration may also vary widely for each individual during their long-term parafunctional activity. Clenching events may not be part of the parafunction, but during unrelated activities requiring maximum effort, for example, weightlifting or other sporting events or work-related efforts. Lifetime exposure to clenching forces as part of the parafunction is unknown. Lifetime exposure to clenching forces as part of strained activities related to work or sports may be more easily determined. Although duration of events and lifetime exposure are not documented, the impact of clenching can be assessed by other features. Alveolar exostosis, for example, an important supporting clinical feature. The vertical form of wear facets, the tight bite or extreme maximum intercuspation. For example, an orthodontist evaluating the occlusion immediately after treatment and again after 6 months observes improved intercuspation. A regimen of clenching would have the same and greater effect. Forces to provide intrusion must include effective anchorage to be able to apply the force. Clenching includes 3 components: clenching muscles, anchoring posterior segment, and opposing intruding segment. Which arch is serving as anchor and which arch is intruding can only be determined by features that reveal where the intrusion occurred. Fixed prostheses, implants, splints, and night guards influence intrusion. Anchorage has been overlooked as an inherent component of clenching. Let's talk about excessive speaking or rest space. Closest speaking space, referred to as CSS, Interocclusal Rest Space, referred to as IRS. Both features are used to evaluate existing and changes in occlusal vertical dimension. If PDI is proposed to have occurred, then CSS and/or IRS must be greater than average or the accepted normal range. Numerous reports identify the mean closest speaking space, and they vary between 1.1 millimeters to 3.5 millimeters. These same studies report low and high values ranging from 0 to 14 millimeters. If posterior dental intrusion has occurred, then vertical dimension has been decreased. It follows that closest speaking space and rest space have increased. If posterior dental intrusion is only suspected to have occurred, determining the patient's closest speaking space or rest space obviously becomes a priority step. If compensatory eruption is proposed to occur, why not check CSS and IRS to indicate average or normal spaces still exist to support that the OVD remains unchanged? This patient presented with a deep bite with approximately 120 to 130% overlap. The closest speaking space is approximately 8 millimeters. Between CSS and IRS, this presenter prefers CSS as the determining factor. IRS is considered by this presenter to be more influenced by other factors. For example, tongue size versus tongue space, size of tori and alveolar exostosis, the contact of lips versus no contact, and other factors. Closer speaking space can be easily observed or even videotaped. Observe the excessive space in the posterior areas at the closest speaking space position. It should be noted that in restoration or reconstruction of worn dentitions or deep bites, increasing vertical dimension is a reluctant or desperate step to acquire clearance for restorative material. Goldstein and others in 1921, in reviewing the literature, report there are anecdotal indications the OVD may be increased up to 4 or 5 millimeters without discomfort of the patient. This presentation may be the first report to justify increasing vertical dimension, based on the awareness of excessive CSS and a diagnosis of posterior dental intrusion. Indeed, this presenter suggests that you may actually be restoring OVD toward, but not to, the patient's normal OVD, especially since the deep bite is an acquired condition. And now we will return to posterior dental intrusion as a clinical feature. Posterior dental intrusion has not been acknowledged to occur, possibly due to tooth intrusion has been considered the most difficult orthodontic movement. Anchorage for orthodontic intrusion of posterior teeth was extremely difficult to achieve and often caused mobility or intrusion of adjacent anchoring teeth. Creekmore in 1983 introduced skeletal anchorage, which resolved the problem of anchorage for intruding entire posterior segments. Skeletal anchorage is often favorably characterized by the term absolute anchorage. Skeletal anchorage may be screws in the alveolar bone, temporary implants, or surgical plates. Anterior open bites are often corrected using skeletal anchorage to intrude entire posterior segments. Orthodontic closure can replace orthognathic surgery for closure in many instances. Anterior closure of 2.2 to 6.9 millimeters is reported to be accomplished by intruding posterior teeth from 1.9 to 3.4 millimeters as measured at the first molar, as depicted in the green column on this report. Orthodontic intrusion is accomplished with 1/10 to half a kilogram force or 100 to 500 grams of force listed in the red column. This table of reports indicates levels of maximum bite force during bruxing or possible clenching in the yellow column, comparing to forces required for orthodontic intrusion of posterior segments, the red and adjacent yellow columns. Maximum bite force is reported to range from 73 to 86 kilograms of force. Forces during bruxism has been reported as 22.5 plus or minus 13 kilograms of force. Orthodontic intrusion is accomplished with 1/10 to half a kilograms of force. If clenching applies a small fraction of maximum bite force, a small fraction, tiny fraction of maximum biting force, there is ample force for intrusion of teeth. Orthodontic open bite correction with posterior intrusion and moderate forces supports the feasibility of patient-induced posterior dental intrusion. Let us review some supporting clinical features that are not required for a diagnosis. Distorted occlusal plane or cervical plane, alveolar exostosis, and mandibular anterior crowding. If PDI occurs, or even if the anterior teeth erupt, the occlusal plane will be distorted. While not typically exposed, visualization of the CEJ from a knowledge of dental anatomy would reveal a distorted cervical plane compared to Wheeler's description. Evaluation of these two planes and mounting dental casts with the aid of a Facebook transfer will determine which posterior segments intruded. These illustrations are not necessarily aligned with the patient's horizontal plane as you observe them. Alveolar exostosis is evidence of excessive occlusal forces. The periodontal literature often describes excessive occlusal forces causing mobility of the teeth and widened periodontal ligament space. Denticians diagnosed with PDI exhibit the extreme opposite in both areas. Mobility is absent beyond normal. What I mean by that is extraction of teeth would be considerably more difficult with PDI. The teeth are solidly anchored, and there's no displaying or drifting of teeth as in posterior bite collapse. Mandibular tori. The literature reports a genetic component in the development of mandibular tori, but environmental factors such as excessive occlusal forces are reported to cause continuing enlargement of tori. Note on the right images, the large tori do not impact the transition of intrusive passive eruption on the posterior teeth, transforming to normal passive eruption on the anterior teeth. Mandibular anterior crowding is a common side effect of PDI. Crowding may occur at any age along with PDI. Anterior wear may reduce the degree of crowding, and conversely, crowding may reduce the degree of anterior wear. Now, there are 8 or 9 theories attempting to explain late mandibular anterior crowding. Once PDI is acknowledged to occur, PDI will be seen as the most likely cause at any age once posterior dental intrusion begins to occur. Now, allow me to add a few general notes regarding posterior dental intrusion. No radiographs are required for a diagnosis of PDI. However, when proceeding to a complete examination and treatment planning, radiographs are essential. Mounted casts with a Facebook transfer are essential for treatment planning. Now, mild or moderate conditions of PDI need not be treated. Patients are comfortable and functional. And if something is needed, preservative dental treatment is recommended, and it's typically done at the patient's current occlusal vertical dimension. But severe PDI may jeopardize the periodontal health of anterior teeth due to severe deep bite contacting the periodontal tissues. It may expose the dental pulp of teeth due to severe wear, and it may actually prevent restorative treatment due to extremely severe anterior wear. All 6 essential features and 3 supporting features were not revealed concurrently, but over several years and after review of numerous topics. At the same time, I have reviewed the diagnosis and etiology with intact dentitions, less third molars and orthodontic directed missing first premolars, and also with few crowns and no implants. But once posterior dental intrusion becomes widely acknowledged, diagnoses may be made confidently of dentitions with less restrictive dental conditions. For example, the dentitions may include a few crowns, a possible implant crown or 2, and other factors. And this concludes the presentation, and I thank you for your attention.